Hi, and welcome to And So Much More. My name is Cami Smith. I'm your host, and I'm here with my friend Jared Vest, who's also a caregiver here at Centra. And we get to talk about some new equipment that we have, new machine that, thanks to really generous donations from Centra Foundation as well as the Al Strubans Foundation, we were able to purchase a PET CT, a cardiac PET CT machine that is new to Centra this year, and very specialized and very cool thing for our community, for our caregivers. And so you know so much more about this than I do, but I do want to go ahead and dig in and hear a little bit about you first. So tell me about your role at Centra. So you're over nuclear medicine, nuclear cardiology, or supervisor for PET CT, correct?
That's correct.
So tell me about that. What do you do on a daily basis?
I'm still somewhat clinical. We do quite a bit of patient studies, but then also, I have to kind of herd the cats, right? So sort of day-to-day stuff. We do quite a bit of organizing. We sort of coordinate patients for the day. If there's outages or we have issues with medications, because all of our medications, we rely on our pharmacies outside the Centra to get us all of our medications. I sort of navigate those changes, staffing, schedules, vacations.
Okay, wow, yeah.
Yeah,
that's a lot.
so quite a bit, yeah.
You make all the wheels turn.
Yeah.
So cardiac PET CT.
Mm-hmm.
Why? Well, first, what is it? Tell us what that is.
Yeah, so traditionally, but I guess we kind of have to go here to go there. So traditionally, Centra has always done SPECT, and SPECT is it's an acronym, kind of like SCUBA, right? So SPECT stands for Single Photon Emission Computed Tomography. There's no quiz at the end of this, but basically, we're doing that. It's a way to image something in 3 dimensions. A way to think about it is like if you close one eye and you look at a pencil on its end, right, at the pointed side. Don't run with it. But if you turn it, you can see that, if you only have one eye, it looks 2-dimensional until you turn it, right? And then it looks 3-dimensional. And so that's sort of what you're doing in SPECT. Is so we're injecting the medicine. We're then rotating the patients. The scanner rotates around the patient and grabs that heart and all the ways around it, right? The beautiful part is that PET, the goal of the exam is still the same, right? We're still looking at blood flow to the heart, being able to figure out how well the heart is performing under stress and rest conditions, making sure it's getting enough blood flow for both. So the main core of the exam is relatively the same. The difference, though, is that PET is able to acquire that. Instead of turning, it actually is acquiring it in 3D all at once.
Oh, wow.
So that
so
part's
very
cool.
different end result.
Very much a different end result. Yeah.
Okay.
Yeah.
Wow. So. Okay, that's fascinating. So I'm going to try to find a picture and insert here so you guys can kind of see what he's talking about.
I can send it.
Yes, thank you. So when we're talking about preventative care, long-term management, and really heart disease, what does this mean for our community now having this technology?
I think unfortunately as it is, I'm from rural West Virginia, and extending into this region, our access for the demographic of patients that we serve here, their access to, thinking that they have to go to UVA or Duke or somewhere to have this adequate level of care, it's right here now, right?
Yeah.
So it really means a lot for our community that we can serve them at such a high level. We had a few members of our board come through and they asked me, they're like, well, how impactful is this, right? And I thought that was a really interesting question. And it was the one question that it kind of took me a minute to think about it. And I said, my answer was it was paradigm shifting. So the only way to put it, we're going from something that was probably extremely, definitely okay, but really getting antiquated as we sort of look forward.
Yeah.
We almost took 2 giant leaps forward. We skipped a whole thing.
I love
in order to get that, right? So quite literally paradigm shifting.
So it's a big deal for those of you who are coming in to, Centra HVI for any kind of cardiac heart disease. This is huge. You don't have to go to UVA. You don't have to make that drive anymore. We have this functionality right here in Lynchburg at LGH.
Yeah, our CAT scanner is at the Strubans CVI Pavilion.
Okay, so I keep hearing this term gold standard. So what does that mean when we're saying this is a gold standard? Yeah,
I mean, so in healthcare, we a lot of times if anybody's ever been to the hospital, there's lots of redundancies built in things. If we can't do a CT, an X-ray, right? You know what I mean? If we can't do an MRI, maybe there's some sort of equivalent, right? Or hey, I'm not really sure if this is, the right exam. Maybe there's some lab work we can pull to sort of make sure that we're getting the right picture. So, I feel like in medicine, we tend to be quite redundant in how much, we're able to look for things or be able to sort of look at a patient and be able to assess them. And so with that being said, this is with that, SPECT, it was sort of used to be the gold standard. It used to be planar until then, but this is now the gold standard, meaning that like this is the what all of the others sort of look up to, right? So the one in the middle is SPECT CT. One of the huge benefits of PET and SPECT CT is the addition of the CT part. So when we hear about it, we see PET CT, and a lot of patients think that it's two different things. And truthfully, it is, right? Because we hear that, if you have to have a CT scan, that's different than having a PET scan. Yeah. But what the CT does is it actually maps the body. And so, if where each patient may carry their weight, whether they're big or small, a lot of times in female populations with their breast tissue, you can get attenuated artifact. Mm-hmm. And a lot of times, like our physicians will see that on imaging, and they'll say, "Oh, well, she's not really having a heart attack. That's just breast tissue attenuation." And what attenuation means is that basically is masking the little bit of radioactive material we have in there, and our tissue is actually kind of shadowing it, so it looks like that heart muscle is not getting blood. Yes, but it is, right? It's just because that breast tissue is there, or somebody like me is a little chubby, right? And so those types of things will affect how that imaging actually looks. And so, so the CT is probably one of the best parts of this whole thing, is so it actually takes each person and will scan them. Wow. and find out where their densities are and where they are not, and it will adjust the image to make sure that it's accurate.
That's crazy. So it's kind of leveling the playing field and making this accessible for everyone, not just technology that's created for your type A individual who is going to fit the normal category.
Right.
I love that. So what does this mean for diagnosis and treatment for heart disease?
Well, one of the questions was, is when we look at volumes and care for our patients, we say, well, how much of this is going to impact patients going to the cath lab or going to echo or having other downstream things? And I think the best way to answer that is to say that this gives us our physicians the best information they need to make sure that the right patients are going there.
Okay.
Right. If you don't need a heart cath, don't have one. Right. Like there's no need to have things you don't need. Right. Like I think in this generation, as it's almost like pop culture now. We don't take things we don't need. Right. Mm-hmm. And that maybe a little older generation maybe would maybe just kind of just keep doing what their physician says or whatever. Yeah. But now everybody is very questioning, and I think that's great to be a part of your own healthcare. Absolutely. And so I think this is another way for our physicians to make sure that we're informing our patients that they can also be a part of that decision to help them make the best decision. And so in cases like this gives us the top-notch information. So our physicians say, hey, you know what? I still think I see a little something. Let's maybe run to the cath lab, and if we see something, we can take care of it. Whereas before, it's like, this is really indeterminate. The next step would be this.
I love that.
Right. And so it's making sure that we're sending the right people to the right treatment and that they're getting the right care.
Well, and it's eliminating probably redundant or unnecessary things that, in the past you just do to make sure and to cross your T's and dot your I's.
That's right.
We can see more clearly on the front end to make better decisions on the back end. And I think that means so much to our community who, nobody wants huge hospital bills, right? Like we just want the things that we need. Let's get straight to the point. Let's find out what's going on. And I think this is huge for that. So you mentioned an older population. What is there like a specific demographic or a specific population that this is going to mean the most for?
Really I think it's just the region, you know what I mean? Like, having just really, we can scan anybody, right?
Yeah, for sure.
And as sad as it is, heart disease sometimes doesn't really discriminate on age. There are, you can pull literature and look at specific demographics and say, African American males from 50 to 65, maybe more likelihood of having prostate cancer or heart disease, or whatever, or white males at this age may be more inclined to have lung cancer. And so I think really at the end of the day, we can always pull stuff like that. But ultimately, in my experience so far, even our patient population has been pretty fair. It's just whoever really needs one and needs to make sure that their heart's working okay.
Yeah.
So it is pretty cool. And the likelihood of them actually having a cardiac event with PET CT after having one and it being clean is about 1%.
Oh, wow.
So
that's huge.
So rest assured,
absolutely.
Yeah, statistically it's about 1%.
Yeah.
So that's
we've
awesome.
had this machine for how long?
I think it was installed in February or March.
Okay. So, you've experienced this. You've seen the before and the after for our patient population. What would you say is just your biggest takeaway? Or what is I don't want to say the most exciting part of it, but as a clinician, what is that like to see something like this that can change so many people's lives?
It's really nice to know that you've caught something. There's patients that maybe have something that they didn't know, and they get the right treatment, and I think just knowing that they're how assured they are that they can place a little bit of that worry on us, right? And they can say, you know what, like, I'm in good hands. I know that the people here know what they're doing. They have the right equipment to do the right job. They have cutting edge stuff. I think for me, it's always nice to have one single positive interaction with a patient, but for a patient to really feel confident that you delivered the best quality care, and that then like they're almost proud of the fact that like they walk out and they know that that like Centra has something this great and this new. To me, like that to me is like, and as a leader now, like that for me has always been more exciting.
Yeah.
So so they can walk away knowing that.
Well, it's very cool to think about the things that Centra, at least from my perspective, in the 5 years that I've been here, they look at the community needs health assessments.
Yeah.
They look at where are our most vulnerable populations. What do our patients need the most? And then we have these incredible partners like the Centra Foundation and the Alice Trubon's Foundation as well, who help us provide things like this based on the needs that have been identified. And that's so intentional. That's not just, hey, bright new shiny machine, let's do it. That's saying, what is going to further our patient outcomes in a way that is going to change lives. And then something like this is brought in. So I think you're right. I think that it says something when you can brag about your local health system and say, hey, we have this thing, because it's going to help so many people, especially with heart disease. And we do see so much of that in our area. Well, is there anything that I haven't asked you that you feel like you just really want our patient community to know?
I mean, I guess for one is, if you feel like you've had something, you pushed it off, right? Know that this test, it only takes about 20 minutes. Total time in the hospital is maybe
nothing.
an hour and a half. That's nothing. And the meanest thing we're going to do to you is start an IV, right? I mean, other than that, it's really not that bad. But and it looks about like the size of like a CT scanner, maybe about two of them put together. So it's pretty open in there. And the whole thing's done in like 20 minutes. You walk out, there's no anesthesia. Like you're not even radioactive by the time you go there. I mean, so like, it really, and really before this, you're talking like a 3 or 4 hour endeavor to do this. And we're
I didn't know that.
4 hours to about 20 minutes for the actual procedure.
Okay, I mean, that alone, you should have led with that.
Yeah, I mean, like
that's huge.
Like, you could like literally do that and then be like, all right, and like I'm gonna go hop on a Teams call or whatever.
Wow. That's unreal.
Yeah.
Awesome.
Minus getting all the glue off of here for the KG leads.
That's
not anybody's favorite part.
Well, thank you for sharing this with us and for kind of giving us an insight. I know when we talk about with our community, like, hey, we have a new cardiac PET CT. Like, for the longest time, I just had no idea what that was. And I think that our average patient, unless you live this, and this is your, you're living in that cardiac world, having a better understanding of what's available here is going to be huge. So thank you for sharing.
Yeah, you're welcome. I definitely think, probably the only other thing I would say is, advantages over traditional SPECT imaging. I mean, not only can we just image the heart, but we can actually watch the blood perfuse into the heart muscle or actually get absorbed in the heart muscle. Okay. And not only can we watch it, and then I want to one up that, not only can we watch it, we can actually quantitate it, which means like we can assign it a value, like in milliliters per second or milliliters per.
And what does that tell you?
And basically, it allows us to assess a patient's ability to actually have extra blood flow on demand in the event you need exercise, right? Because as you and I are sitting now, hopefully our hearts are beating. But basically, we have a certain amount of blood that needs to go to the heart, right? But then if we go and take off and let's say we need to run across the room or run up a set of stairs, right? Our bodies need blood. Our blood chemistry starts to change, and that tells our heart that it's like, hey, we need more resources, and we need to get that blood to you. Well, the heart also needs its own resources, so it has to feed itself blood so that it can also meet the demand of the body. Okay. And so when stress happens, a lot of our arteries and veins will dilate to make up for that extra volume of blood that we need to do whatever exercise that we need to do. And so we can measure that now with this piece of equipment, that we can actually measure how much of that you have on hand as what we call reserve. Okay. And we can map that. What that then allows us to do for imaging, so we can image it, we can quantitate how much of it is present. And then it also then allows us to not even look at the ability for us to see smaller defects is way higher than it was prior. It had to be a relatively, decent size defect, meaning like an infarct or a blockage somewhere.
Yeah.
For us for the scanner to see it. And it's sensitive. I mean, it's not bad, right? But this now is we're finding what we call microvascular disease, which is
wow,
tiny blockages that you may not even know that you had.
That over time could lead to big
Correct.
issues.
Yeah.
Wow. Okay.
So yeah, so that part of it's cool. They do calcium scoring with it. And then I would say for the future, and we maybe talk about this a whole nother time, is like what else does this test lead to? Well, obviously we send patients to cath, but sometimes the next step after that, it's like, well, we can cath it. We don't know if that heart muscle is still alive, and then we're going to introduce another program, hopefully into this year, beginning of next year, where we then are going to be able to use that same scanner, and actually be able to assess whether that heart muscle is still what we call viable.
Wow.
And it involves a little bit of funny blood chemistry. We mess with the patient's blood sugar a little bit, and we can actually assess whether that heart muscle is still alive to even know if the intervention is worth doing.
Wow.
And so again, getting the right patient to the right right study, the right intervention. Yeah.
That's incredible.
So, yeah.
Well, we'll have to talk about that when you guys get that in place. You can come back and give us an update.
Yeah.
Well, thank you so much.
Of course.
I appreciate your time. Yeah. And thank you guys for joining us on And So Much More.